Hello friends and welcome back to Parshetti's Pharmacology. Today we'll be studying one of the most important topic, that is Gold 2025, the newer updates compared to the previous Gold 2024. Gold is a body which forms guidelines for management of chronic obstructive pulmonary disease, that is a COPD. Okay. Totally I have brought to 11 major changes from 24 to 25. We're studying in brief regarding all these changes. Okay. Coming to the first change, that is pre and post bronchodilator FE1 by FEC. We all know this, but this time he has put it in a flowchart. Whenever the patient with symptoms of COPD, along with the history of exposure to smoking or the pollutants or other genetic factors, come to us in OPD to confirm COPD. What we do, we measure pre bronchodilator FE1 by FEC. If it is more than equal to 0.7, then it is not COPD. Then we do, if FEM FEC is less than 0.7, then we do post bronchodilator FEM by FEC. Again, if it is more than, if it is more than equal to 0.7, again it is not COPD. If it is less than 0.7, then COPD is confirmed. So remember, always to confirm COPD, we need post bronchodilator FEV1 by FEC, and it should be less than 0.7. Okay. Second change, follow-up management of the patient already on LABA and ICS. The patient is currently on LABA ICS and there is no exacerbation and is currently doing good, and the symptom load is low. That is, there is no cough and the dyspnea is under control. We continue with LABA and ICS. If there is high symptom load, that the patient has persistent cough, dyspnea around grade 3 or grade 4, then we shift it to the LABA, LAMA plus ICS. Second, the patient on LABA ICS, no relevant exacerbation history in the past, then we shift it to the LABA plus LAMA. If the patient on LABA and ICS but continues to have exacerbation, then we see for the blood eosinophil level. If it is less than 100, we change it to LABA and LAMA. If it is more than 100, we convert it to the triple combination, that is LABA, LAMA and ICS. So this is the change which I mentioned regarding the LABA and ICS management. Coming to the COPD and pulmonary hypertension, a newer table added here. It can be divided into three major categories, that is COPD with group 1 pH, that is the idiopathic one. Second, with chronic thromboembolism phenomena, that is group 4. And third, the most common associated with hypoxia. So any patient of COPD with pulmonary hypertension comes to us, we should not directly label it with the group 3. We need to even rule out group 1 and group 4. Okay, we need to always rule out pulmonary embolism as an associated risk factor for pulmonary hypertension in patient with COPD, because COPD is a risk factor for pulmonary hypertension or embolism. Fourth, vaccination, stable COPD, 6 vaccination. Influenza yearly, as we all know. Second, PCV 21 or PCV 20. Third, COVID according to the local guidelines. Fourth, zoster for more than equal to 50 years. Tdap if not immunized in the adolescence. Then respiratory syncytial virus if age is more than equal to 60. Or the patient has chronic heart disease associated with chronic lung disorders. So 6 vaccination for COPD. Follow pharmacological treatment for dyspnea and exacerbation. There are two major additions. In dyspnea, the patient is on LABA or LAMA. If the patient persists to have dyspnea, we need to check the inhaler technique. Then compliance with the treatment. If everything is good, we need to rule out even the associated risk factors. Like if the patient is persistent active smoker, or if the patient has heart failure, it could be either systolic or diastolic, that need to be treated. If everything is done, even with that patient need persist to have dyspnea, we need to shift it to LABA and LAMA. Even with that, the patient persists to have dyspnea, we can add ensifentrine, which is the newer molecule. So what is ensifentrine, we'll study in the subsequent slides. In exacerbation, if the patient is on LABA or LAMA, then rule out all the risk factors like the inhaler technique, compliance with the treatment, associated risk factors, everything is ruled out. Even with that, patient continues to have exacerbation, check for the blood eosinophil. Blood eosinophil, if it is more than 300, directly shifted to LABA, LAMA plus ICS. Even with that, the patient persists to have exacerbation, then you can go for dupilumab, which is a newer biological in the COPD. So what is dupilumab? We'll study in the subsequent slides. If the blood eosinophil is less than 300, LABA plus LAMA. Even with that, the patient persists to have exacerbation. Again, check for blood eosinophil. If it is less than 100, then go directly for roflumilast or azithromycin. If it is more than 100, more than equal to 100, then give LABA, LAMA plus ICS. Roflumilast we give in patient with chronic bronchitis and low FEV1, that is less than 50% of the predicted. Azithromycin in mainly the patient with preferentially former smokers. Okay, ensifentrine, dupilumab we'll study in subsequent slides. Coming to the trajectory of the lung function, there are categories like supranormal, normal, pseudonormal, below normal, accelerated decline, and growth failure and catch up. As you all know, the lung development begins in utero and persists till and keeps on growing till puberty, that is 18 to 20 years of the age. During puberty, patients can have supranormal lung function. Then, so we call it as supranormal, the normal which most of us have. Then some patient till the age of 18 to 20 will have poor lung function, but in the last 1 to 2 years they can catch up. That is known as catch up. And from below normal they become the normal. From below normal they become the normal lung function. Some patients will have growth failure. Till puberty they'll be having good amount of lung functions, and during last 1 to 2 years they'll have growth failure. It could be because of the nutrition or because of the smoking or because of the environment. Then they will have below normal. Some patients will have premature death because of the failure of the lung development, again because of the GET, that is genomics, environment, and the time period of exposure. Okay, these are the supranormal, normal, pseudonormal, below normal, and accelerated decline trajectory of lung function. Right. What is dysbiosis? Biosis is the normal microbiome. This is any disruption in the normal lung flora. Previously, lung was considered as a sterile organ, but further studies showed that the lung has a home to immense number of the flora. This flora is important in order to maintain the normal lung functions. Okay. In patients of COPD, there will be a disruption in the various compartment, not in the airway, even in the parenchyma. It could be because of the recurrent antibiotic use, recurrent steroid use, or because of the smoking, which is an important risk factor, or because of the pollutant exposure. This leads to increased frequency of the exacerbation. So this is what a dysbiosis means. Okay, dysbiosis lead to increased frequency of the exacerbation. Coming to COPD and cardiovascular disorder, as we all know, lung and heart almost goes hand in hand. If one is affected, other subsequently gets affected in the meantime or suddenly. So the presence of cardiovascular disorders like arterial hypertension, coronary heart disease, heart failure, arrhythmia increase in patients of COPD. So why? One is because of age and smoking, which is a common risk factors for both CVD and COPD. Persistent inflammation causing endothelial dysfunction and coagulation abnormality. Abnormal gas exchange. Lung hyperinflation causing reduced venous return and therefore reduced cardiac output. Reduced physical activity because of the exertional dyspnea as an independent risk factor for CVD. Patients of COPD have reduced physical activity because they feel that on exertion they'll have the dyspnea, so they restrict the physical activity as a risk factor for cardiovascular disorder. Failure of heart on lungs can cause bronchial edema. Reduced skeletal muscle blood supply because of the reduced cardiac output. Third, post-capillary pulmonary hypertension because of the left heart failure or because of the valvular disorders like mitral stenosis or MR. Coming to phosphodiesterase 3 and 4 inhibitor, which I was talking was ensifentrine. It is a dual. It has both phosphodiesterase 3 and 4, which acts as both anti-inflammatory and bronchodilator activity. So it acts mainly on the cyclical guanylyl monophosphate modulation, and which causes a smooth muscle dilatation or the relaxation. Okay, which helps mainly in the dyspnea table. Okay, remember. It is given by the nebulized form. For my information, it is not yet available in India. It is available currently in the US. Dupilumab, a newer biological added in the COPD according to the Boreas trial. It is a dual one. Okay, anti-interleukin 4 and 13. Okay, even ensifentrine was dual, then this is dual. Remember, it is mainly for the patient to have moderate and severe exacerbation, recurrent. Second, chronic bronchitis. Third, eosinophil count should be more than or equal to 300. Remember, okay, these are the three indications: recurrent exacerbation, chronic bronchitis, eosinophil more than or equal to 300. Coming to the climate and COPD, as we all know, the climate has a major impact on the COPD patient, whether it not only cold, even the heat. Okay, remember. So what he says is that during autumn, the outside temperature is 10.1 and the indoor temperature is 10.1, outside temperature is 2.9. But in order to prevent the exacerbation, we need to have the room temperature of around 21 degree for at least 10 hours a day. So it is recommended to use room heater in patients of COPD during winters. Okay, remember. And during winter, it is not just because of the cold, even it is because of the pollutants, which can have increased hospital admissions and emergency visit and even subsequent mortality. Okay, remember, both cold and heat can cause exacerbations in COPD. So always recommended to maintain the room temperature more than 21 degrees Celsius. Okay, this is regarding climate and COPD. If you have any doubt, please